be able to welcome Rebecca's here. So Rebecca and I have actually worked together for years. She's a nurse practitioner in both neurosurgery at Children's Hospital Oakland, so I don't know if you'll work together clinically, as well as in the PICU here. So for those who rotate through the PICU, you might have an opportunity to work together clinically as well. But in addition to all of that, she's also the director for the Center for Global Nursing here at IHS, and she has her PhD in, what's the full title?
Oh, the DMP in global health education.
So she's really an expert and has worked everywhere in the world and is the nursing lead for the collaborating center with the WHO that I was telling you about this morning. So she's actually directly working with the WHO to develop curriculum that will then be taught globally. We're really, really fortunate to have Rebecca here.
Oh, thank you so much for that. Yes, I love her. She's amazing. The best part about global health is that there's amazing people that do it, and you get to work with incredible collaborators across disciplines. So today, I'm so excited to share with you a little bit about me and a little bit about global nursing and how we get to work together with you guys as you enter your careers, and kind of the value of nursing and working with nurses, because we do a lot, and I'm really excited to share about it. So as Teresa mentioned, this is our organizational chart here at Institute of Global Health Sciences. And there's now, we added the Center for Tuberculosis. So we have 8 centers. And the fourth one over from the right is our Center for Global Nursing, which is a really big step for UCSF. We have our School of Nursing has an extraordinary history. It's the #1 NIH funded nursing school in the country. And they have a very large global nursing research presence. And that was kind of the history of global health and nursing at UCSF. But the reality is that there was a lot of us, and me being one of them, that were on the UCSF health side, that are clinicians that also have worked with NGOs and all this stuff at UCSF. And we didn't know how to bring everybody together. How do we bring these like expert researchers with these expert clinicians and like share the wealth and the great stuff that nursing does? And I think different than a lot of our physician colleagues who kind of do both and have an appointment at the School of Medicine, and also our clinicians, nursing and advanced practice, we're a little bit different based on the union and all these things that are coming to fruition. And so a lot of this stuff that our clinicians are doing on the global health end, like nobody at UCSF knew that I existed until this one day was like, you do education, right? October 26, 2021 of the PICU, I'll never forget this day, because she's the reason why I got to get involved in the Center for Health Equity and Global Surgery, because she was like, Rebecca has this skill set, and it's really something that we're looking for in the work that we're doing in educating folks for COVID-19, because my expertise is global health, critical care, and so I was able to join in some of the work. And from there, we were like, we need more nurses here. Like, why am I the only one? And we built this center. So as Teresa mentioned, I've been lucky enough to work all over the world. I've worked as a nurse practitioner, a nurse, and a nurse educator in more than 20 countries, setting up ICUs, doing surgical health system strengthening. It has been my honor and my privilege and the love of my life. And so it's really exciting to be here and share some of that with you. Global nursing, let's dial it back to the nitty gritty. So why are nurses important when we think about global health, and why is it so important that we have the Center for Global Nursing at UCSF and that we all engage together? Well, we make up 60% of the global workforce. So 20 million nurses are working around the world, and that's huge. We know that they dominate population health impact just by numbers. If everybody contributed equally to patient care, we would know nurses would make the biggest impact just by numbers alone. And when we look at the data, this is from the National Institute of Medicine and our National Academy of Medicine and the WHO. When we look at things, we know that nurses, and I love this infographic from WHO on their 2020 report on nursing, but it really shows that we are part of this team. Nurses don't want to be independent, like physicians probably don't want to be independent in their work. We know as healthcare providers, working in a team, we can really optimize the population health impact. And so universal health coverage, we need nurses for that. They really provide gaps where we don't have other providers and other teams. We know that they're essential in addressing social determinants of health. We have so many researchers at the School of Nursing looking at that in health and well-being. And I fall in this little emergency, epidemic, disasters, critical care, but we provide clinical care and clinical training and we help our partners across the globe up level and bring themselves into their highest ability to contribute to patient care. So if you guys were at I did grand rounds and talked a little bit about some of these figures, but we'll put a pediatric spin on it, and we'll talk more about how it directly impacts our work as pediatric providers. So I'm really excited to be here with pediatric providers, actually, because usually it's just global health. So this you guys are my delight. But nursing density. So, at UCSF, you're training here. We talk about nursing shortages all the time. We turn patients away because we don't have nurses. And that's because we have really strict regulation around nurse to patient ratios. And that's because there's been a lot of data looking at what is safe for patients. What do patients need in terms of nursing care to be safe? And we are the gold standard for what safety is here in California because we have things well regulated. But then if you look at how many nurses we have per 10,000 population, we have more than any other country aside from our counterparts, some in Europe and parts of Brazil and Australia. We have had a lot of nurses. But the problem when you look at this picture is that over 80% of the world's nurses are found and only account for half of the population. So when you think about, in a room of 100 people, 80 of the nurses only take care of half of the population. Those other 20% are in countries that are really trying to meet the needs of the population. But it's really challenging. And you see this often when you think about when I go to CHO and I'm on the wards, and I'm like, how many patients do you have? They're like 4. When I was rounding an AMPATH in Kenya in May, one nurse on an oncology ward had 60 patients. And you can see how that is such a challenge. And especially if you're going to be working with nurses and you're like, oh, I think, the nurse can do X, Y, or Z. She has that skill. I want her to use her maximum practice. Then she's like, well, how do I do that when I have 60 patients? And so recognizing how this number impacts the nurses on the ground really helps when we work together as a team to kind of understand what everybody's challenges are facing. We've seen it like a little bit differentiated when I work in Haiti. In a private hospital, it's 1 to 10 on a ward and 1 to 4 in an ICU, which 1 to 4 in an ICU is similar to like Columbia if you work in New York. I did that when I was a travel nurse. But then, 1 to 30, 1 to 40 in a public hospital, and even in some of like the long-term care, it's like 1 to 80. So it's a real challenge in terms of having enough nurses to meet the needs of the population. And then when you think about a nurse is a nurse is a nurse, well, this is also not true. It's not true here in America, and it's not true anywhere else in the world. So you guys know at UCSF, I'm a nurse practitioner, so I'm an advanced practice nurse. We have clinical nurse specialists, clinical nurse educators, nurse managers. We have nursing I think we have nursing assistants. And then we have our bedside nurses. The amount of titles for nurses and the amount of education preparation is so varied and so different. And that's really the same if you go anywhere in the world. We have, I would say, in high-income countries, there's more access and accessibility to additional training and education for baseline levels. But when you go to Africa, Asia, South America, you'll find really similar differences in training, in role, and we'll talk a little bit about role and specialization. So if you're here at UCSF, similar to physicians, we know that our nurses are specialized. So like an ICU nurse, it works in the ICU, and if she floats to another ward, she gets paid more, she gets a special assignment, and like it's hard because you realize practicing, if I'm an ICU person and I get told to go to oncology and give chemotherapy, like I wouldn't know how to do that, right? Similar to Teresa got told to go prescribe chemotherapy, she'd be like, I'm sorry, not my thing. But the reality is that there are nurses, that's not standardized around the world, and a lot of nurses just rotate. So there was this great study. So Julia Chalinor I think she said she's retired, but she's still adjunct faculty. She's an amazing nurse researcher from our school who did a lot of work with childhood cancer. And one of the papers they published in 2019 is really helping advocate for specialization in nurses in peds oncology, which is her field, but also looking at what are the benefits to specializing in nursing in LMICs, and what is the barriers. And so safe environment, obviously if you're going to give chemotherapy, there's a lot of precautions to think about, the handling of the drug, the protection of the staff and the patients, and then obviously improving quality of care. If you understand the need for these medications, the timing for these medications, if you rotate on all the different wards and you see that like the nurses have a specific time for everything, they also anticipate side effects, risks. You can improve quality of care if you have a consistent caregiver. And then the barriers are nursing rotation, retention, and migration. So the one, we have large nursing organizations that are looking at these things, but from a staffing perspective, from a hospital, they like nurses to actually be experts in everything and rotate everywhere. And you can imagine that if you're taking care of adult dialysis and pediatric oncology and you're in the emergency room, that it's really hard to become an expert of everything. I'm sure with your rotations, you guys are like, I'm not an expert in anything yet. But it's similar for nursing, and to have that be the quality of care, you could see how that would suffer with the rotation. And obviously retention and migration are a really big problem. We train expert clinicians in different areas of the world, and they're just being recruited to high-income countries that are having nursing shortages. And so I was in a program when we trained pediatric critical care trainers in virtual simulation. And all 4 of our trainers the next year were recruited and moved to the UK. And it's a real big challenge, and it's something where there's a lot of ethical things that we think about because, obviously they're like, Rebecca, like I can support my family if I move up there. It's not gonna be fun for me, but I can help them, I can support them, I get better wages, I'll have opportunities for education. But then you're like, well, you're this expert that can help your community. And so the International Council of Nurses and WHO are really trying to help governments. That feels like a way forward for this because it's the #1 challenge in low-income countries at this time when we specialize trained nurses. There's an amazing program in Ghana that specializes in pediatric nurse training. They partnered with Sick Kids in Toronto, and they built a 1-year training program and got funding for 330 nurses to get trained in pediatrics in 4 years, which is huge because in most LMICs, and I think the data is on another slide, but 80%, I think, of kids in LMICs are being taken care of by general providers and general nurses without specific training. And so they were like, we're gonna train up our staff. And they looked at the outcomes. They did pre and post tests. After the training, they did follow focus groups for qualitative outcomes. They looked at 1 year, what is their skill like? And it was great to see that even a 1-year training program can really help increase knowledge, confidence, and skills. And it increased their job satisfaction and their rank and salary at their current employer. And they also found that the graduates were all competent 1 year later. So it really is a tribute to if you can build specialized training programs, it can help with retention and help increase satisfaction, which is really exciting. There was Jed Williams, he's the head of the World Federation of Critical Care Nurses. I will see him in October in Geneva. Yes. And we've talked a lot about critical care nursing because we're both passionate about it. And he wrote this paper with some colleagues they reviewed all the papers talking about critical care nursing around the globe. They did the scoping review in 2021, and they said, it's actually not a universal role. And this is another thing that makes it really hard when we look at things from, big picture, like what is critical care nursing? And it's really unique to its regional and socioeconomic context because they work in these complex teams with different populations, different resources, and different treatments. And so I'm a pediatric critical care nurse here, but if I go meet a pediatric critical care nurse, our jobs, our scope of what we do, it can all be really different. And I could say that because I worked with critical care nurses from the Philippines, and they're like, oh, you're a nurse and you can give morphine. In our country, where physicians are the only ones allowed to give opioids. Even just the simplest things like that. In some countries, physicians, in this ICU I worked at in India, only physicians were allowed to do lab draws. So your skill would need to be higher in phlebotomy, right? Versus the nurses. And so it's really there's not a universal role for nursing, especially as we look at more specialized things like peds critical care. In Malawi, they're actually building a peds critical care master's pathway, which is one of the first in Africa, which is really exciting. And they did a needs assessment, which, looking at the ABCDE kind of way of an approach to understanding their skills. And they surveyed 153 nurses about their confidence and skills. And it was interesting because they had high confidence in some really good things like airway breathing, but struggled with some of the more complex skills of mechanical ventilation, ABGs, arterial blood gases, and ECGs, which is pretty in line with some of the data you would even find here in our ICUs. So I was not that impressed by the findings, but what was interesting was that 65% of the nurses had training in like emergency triage, but only 50% of these nurses had any training in like CPAP or BiPAP or anything before mechanical ventilation. So it's like there's a lot of gaps in training, and nurses did not even feel comfortable. They might have felt comfortable in airway breathing, but they didn't feel comfortable with like cardiac assessment. Which, when you think about it, I learned a cardiac assessment right with AB, airway and breathing. So the skill level based on the training that they're getting, sorry, is I wouldn't say it's surprising, but I would say it's inconsistent. And when we work with nurses around the world, understanding their training is really important because it will allude to what they can do for patient care and how you guys can work together. Excuse me. But the biggest thing for this study is that it's having a skill is one thing, but if you work in critical care, having critical thinking is another. And this study didn't look at critical thinking at all. So it'd be interesting to follow that up. Sorry. Which would be an even higher level. And I am lucky enough to have gone to University of Cape Town this last December and work with, here's these pictures of these amazing people. This is the nursing development unit at the Red Cross Children's Hospital. And I know one of them.
Global health rotation there.
Yeah, it's amazing,
It's
right?
amazing.
Yeah, so I spent some time there in December, and they have an entire unit developed, dedicated to developing pediatric nursing. And it's just one of its kind in Africa. It's amazing. And they launched a Master's of Childhood Nursing, and through excuse me, I might get this wrong, but through an agreement across Africa, students from anywhere can really take these courses, which is really exciting. And so they launched this program in 2016, and more than 30 nurses have graduated from the program, studying like basic science and pediatrics, becoming experts back in their own countries, in their own regions. They're really training leaders in pediatric nursing, and it's really exciting to see the work that they've done and the impact that they continue to make. They run short courses online, even on tracheostomy care for children. And there's a basic critical care course. There's they're looking at a basic pediatric assessment course that they're about to launch. They just emailed me about. So it's just an incredible, there's lots of amazing work being done. And I'm most familiar with the work being done in Asia and Africa, but I know these things are being done in other regions of the world as well. And it wouldn't be a collaborative, multidisciplinary talk, and especially talking about global nursing, if we didn't talk a little bit about task shifting and task sharing. I don't know if it's come up in any of your training and education so far, but it's a big deal. And the WHO actually talks about it a lot. So it's the transfer of less specialized skills and tasks to less specialized and or different trained cadres. So it's a redistribution of tasks from what would typically be expected. And it's not limited to nursing. This is what happens when we engage our community health workers in healthcare assessment and education. This is us trying to reach universal health coverage by using the skills of our entire community. But this happens really often when nurses and midwives are performing tasks that would normally be considered under the scope of a physician, just because there's nobody else to provide that care. And so task shifting, gosh, this is one of the reasons. So Kenya is a great example. I can give you guys all the references, but this is an article called The Pediatrician Workforce and its role in addressing neonatal, child, and adolescent care and healthcare in Kenya. And it was the group from the Wellcome Trust that published this, and they kind of outlined all the pediatric providers in Kenya. And this is the one, I think, speaking about how little availability there is for specialized, even physicians and nurses. But there's only 305 practicing physicians, 1.33 per 100,000 individuals. That's obviously not what we have here, right? And not what we would hope to meet the needs of this population. And then 21 out of 47 Kenyan counties, there are only one pediatrician, which is why there's so many non-specialist healthcare workers task shifting and task sharing. That's why they're like, we need nurses to actually start seeing patients and doing advanced care options. This is another study called Task Sharing in Pediatric and Child Health Service Delivery, Low and Middle Income Countries. A group from Oxford looked at this, and they wanted to kind of understand like how task sharing has worked in Kenya, Uganda, Tanzania, Malawi, and South Africa. 83 dies, 30, no, 83 is not, that's a typo. I apologize. I think it's 83 areas and 24 LMICs. But what they found was training opportunities are needed to support this role because what, their overall thing was, hey, pediatric kids that are sicker are staying alive longer. We have more complex and chronic conditions. So we need more pediatric providers. We cannot graduate this amount of physicians every single year. We're actually losing physicians to brain drain. So what do we need to do? And they're like, we need to engage non-physician clinicians. And we know that the formal scope of practice for nurses says you can only do this. But what countries are dealing with is this high burden of disease, and they're like, how can we do this? And they're like, task sharing is really the answer in the short term while we work on long-term health system development. And task shifting, this is a paper. Alison Squires is an incredible nurse researcher at NYU, and she looks a lot at workforce. And what was really important out of this paper that she published in 2020 was that while task shifting may help meet the needs of the population, performing this informally can be catastrophic in terms of quality of care for patients and protection of the professionals involved. So if we're task shifting, if we're asking people to do things that they're not trained to do, obviously we can imagine that. I mean, people are doing amazing things, but this isn't fair to them either. And this can result in patients not actually getting the care that they need, even though there's bodies really trying to do that. WHO is working on it with their human resources and health workforce data, but really challenging the balance of urgency of implementation of task sharing with formal education preparedness. And that's where we go when we start looking at advanced practice nursing. I was invited to speak at the conference in Kenya in Eldoret, where this is the Ministry of Health and the Chief Nursing Officer from the the Kenyan Council of Nursing, and I was speaking with two of the master's prepared nurses in Kenya on the right, talking about advanced practice nursing and how the opportunity to provide education in management, diagnosis, and treatment can really help prepare that workforce. And we know that this is what's happened in America. We know that by 2036, the US is going to be short, 86,000 physicians. And that's why nurse practitioners exist, right? To fill that gap and to help do the things that can be done. And so the pediatric, to address the pediatric workforce in Kenya, and this is one of the things that's high on the agenda for the Nursing Council of Kenya and for the hospitals that were engaged. We had multiple, I think 4 deans from different schools talking about how can we build this training. The ministries and the Nursing Council of Kenya saying, how can we build a scope? They've gotten a grant from, I think, InterHealth to build this up. And so it's exciting to see where that could go, because that task shifting without training can be dangerous. Mm-hmm. And then looking at pediatric oncology advanced practice nursing and how it's been successful or challenging in Pakistan, Cameroon, and Turkey and Mexico. This is a great study looking at how it impacts workforce shortages, facilitated time care delivery, but challenged by the traditional structures, role overlap, role complexity. I mean, we deal with this in the US all the time as nurse practitioners and advanced practice providers. So, but it's exciting that there is this level of nursing that can help fill the gap in pediatrics, and they can be colleagues working with you alongside with some of your global health work. So another group of amazing people, and the more familiar version of advanced practice nursing, is really anesthesia. So this is data from the World Federation of Surgery and Anesthesia, WFSA. They were able to survey 97% of the global population and found that anesthetist, the colors are anesthetist per 100,000, and they recommended 4 to 5 are needed for safety. So you can see how many countries are in areas where they're lacking anesthesia care, and that includes pediatrics. And what's interesting is that this data also included, they call it non-physician anesthesia providers, because they're not all nurses in this area. But I think it said even when they're included, 70 countries still had, even when non-physician anesthesia providers are included, which include our nurse anesthetists, there were still 70 countries that had less than 5, which is crazy. So they would need over 136,000 additional anesthesia providers in order to meet the needs of all our global population, which is crazy. So nurse anesthetists, they have an international federation, and they did another workforce study looking at where nurse anesthetists are working, and they're working in more than 80% of all anesthesia cases around the world. And in most of those, they're the sole provider. There isn't a physician. Here at UCSF, we have an amazing model of advanced practice where we work with in collaboration with our physicians that have greater training and education than us. And that's not an option for nurse anesthetists around the world. And this follow-up study on nurse anesthetists in Africa, 37 of 54 countries utilize solely nurse anesthetists. They provide 90% of anesthesia in sub-Saharan Africa and 100% of rural anesthesia. It's just amazing what nurses do as they impact global health, and how, yeah, they also have a higher rate. What's interesting about nurse anesthetists is they have a higher rate of retention in Africa than any other nursing profession. But I think it's, you know, if you go back to the things that make nurses happy, it's financial, it's respect, it's professional development, it's enjoying your role, so, and being overburdened. I've been lucky enough to collaborate with colleagues. I've been lucky enough to work with colleagues at La France Hospital for Children since 2016, the year after they opened. So they opened a pediatric hospital. There's only one pediatric hospital in all of Laos, which is in the capital. This is about a 6 to 8 hour drive, like through the mountains, to get to the northern region. But they see about 38,000 children family in the hospital. 13 departments, 52 pediatric beds, 24 neonatal. Now there's 6 ICU. There's a 4-bed, kind of 6 emergency room. They have a lot of employees, and they have an outreach program that reaches over 1,500 patients, and they go by car to villages, provide education, training, and follow-up for some of our patients. It's an incredible place, and I've been lucky to kind of partner with them in some of the critical care development, and I love those people in those pictures. So why I mentioned them today is, first of all, when we opened the hospital, all the nurses were new graduates. It's, you know, once you have a job as a nurse, you're kind of good for life in this country. So we hired all new graduates, and they're an incredible group of people who have surpassed everybody's wildest expectations. And so one of the places where nurses create the most impact independently is in the surgical care at La France Hospital. We opened the OR in July 2016, and with just nurses as part of the team, and an outside consultant surgeon, they've been able to open an additional minor procedure room and do and provide surgical care in this hospital. So the adult surgeon still comes over. The second pediatric surgeon in all of Laos is currently being trained in the capital, Dr. V. And until he's fully trained, we still work with the adult surgeons that come from the adult hospital. But it's amazing that by having nurse anesthetist, scrub nurse, and a nurse that the nurse manager, Bandy, also he closes and like surgical assists, that they're able to do all these surgeries and provide access to care for pediatric patients where they otherwise would not have received care in a pediatric specialized facility. And one of the great honors of my entire life thus far was in February when I got to the Center for Global Nursing sponsored the OR team of nurses and Dr. V, the second surgeon, to go to the Global Initiative for Children's Surgery Conference in the Philippines and share about their journey providing surgical care in northern Laos. They had never crossed an ocean or been over abroad, and they were able to collaborate with partners from the Philippines, Vietnam, for all over Southeast Asia and all over Africa, actually, and share their work. And it was a pretty cool day. I mentioned earlier that there's a few big kind of people working on nursing regulation and development, recognizing the impact of nurses on global health sciences. They realize that it's their job to help drive forward professional practice regulation. And the International Council of Nurses works really closely with the World Health Organization, providing position statements, scope, education. I said I'm going to their advanced practice meeting, speaking there in September in Scotland. And they're fully driven to kind of help nurses work on driving, increasing the quality of care, increasing our scope, increasing our practice, and really helping advocate for nurses around the world. WHO, Dr. Amelia Tulipo she's from Tonga. She took over, I want to say a year and a half ago from Elizabeth Aro. She's an incredible, she's focusing on the BEC and getting 25% of nurses trained in basic emergency care in 25 countries by 2025. So nurses do all this amazing work. And yes, we talked about that there are nursing shortage around the world, but there's also other challenges for nurses. And one is, of course, education. We know that education creep, getting faculty here in the United States is a problem, actually. Nursing faculty are hard to come by, and I think mostly because, in my humble opinion, it's because we mostly separate our clinicians from our educators, and we should we should all teach, and I don't know, I love your model. I digress. But there's really a lackage and a shortage of faculty in other countries. There's a lot of data talking about how people are looking for a job, so they'll go straight from being a student to a faculty member without mentorship, without additional training, and they lack clinical experience. They also lack resources for training. I know at the Center for Global Nursing, we get a lot of our global partners reaching out saying, Rebecca, like, how do we do simulation in our hospital? How do we work on the scientific development of our staff and our students? Like, how do we do this? We don't have anybody to lean on in our region. And so it can be really challenging to train that next generation of nurses. Additionally, we talked about migration and that we have a shortage of expert nursing just because so many are migrating once they're really well trained and once they have a skill set. Unfortunately, and fortunately, there's a lot of challenges for countries facing this challenge, and it's really hard. And then there's the one concept that I find as I studied education and global health for a really long time, and particularly in the nursing data, we have this term called knowledge to practice gap. And I think in a lot of the medical literature, it's called the no-do gap. But really one of the biggest challenges that we find is that we, in the textbooks, which are all written by mostly high-income countries, using data from high-income countries, for example, placing a Foley catheter will tell you in your textbook that it's important for you to wash your hands in the sink, don sterile gloves, have your sterile equipment laid out, your Foley, your lubricant, your syringe, your sterile water. And so the students will learn all of this in the classroom, they'll read it in the book, they'll understand the literature, and then they're going to go to their hospital and they're going to be like, well, where's the sink? Where's the sterile gloves? Where is X, Y, or Z supplies? And when I look at you, who's a really senior nurse, I don't see you doing it that way at all. So how do I practice? It has led to, there's a bunch of data, a lot of it coming from like the Asia region, Philippines, China, talking about how that challenge of knowledge to practice gap really challenges and creates problems of standardization of nursing. And it really highlights the imbalance and equity in our data that we're pulling in this world, and how we really need to invest in our global partners and find out, well, what is the best Foley catheter standard procedure for this region of the world? Because it might not be what's best in my region. And it's created a lot of lack of confidence in nursing, because nurses, they always assume when I walk into a room that I know better, that I know more, that I've done it the right way because I have the resources. And I think what I've come to learn doing a lot of quality improvement work in low and middle income countries is actually that, like, what works here doesn't always work there, and what is needed here isn't always needed there. And so we all of the nurses that go through our program at the Center for Global Nursing get to take a culture humility class, which really teaches us just this. Like, I'm an expert in my field, in my place, and where I work. I'm not an expert for you, but I understand their challenges and being like, well, I want to give the best care to my patient. And I'm reading a book that says this is the best care, and I'm going to my clinical site and I can't do that. And then it takes time for them as clinicians to practice and learn from their own work. And then that's how they build their own best practice, which is where we can maybe partner and say, how can we help define what is best practice for you? What have you been doing? What are you seeing? What are your questions? And really help unveil the things that nursing, especially, is providing central line dressing changes. I know at UCSF, that's an every 7-day thing. Well, if you don't have enough supplies for every 7-day thing, well, have we done any studies? Have we looked at any of that data just before we share all of our best practices? And I say that in quotes for a reason, because they're only my best practices, they're not yours. And so I think our global nurses face challenges, and then when we partner with them, we face the same challenges of like not having the answers, but being able to work together to identify some things. And then as we work to kind of improve the skills of the workforce, there's this great article, Global Initiative for Children's Surgery, I mentioned earlier. This is an article by one of their team leaders where they did this, as they called it, South to South, but India to Africa exchanges for surgical development. And they brought surgeons and anesthetists and nurses, from Africa to India, and then they trained trainers and sent them back home, because 1.7 billion children worldwide lack access to surgical care. And 3%, less than 3% have access to it in low income countries, and less than 8% in low and middle income countries. So how can we improve access to surgical care for our pediatric patients? And we need nurses to be able to do this. Most anesthetists are going to be our nurses. So how can we train that team? And this is part of what we love to do at the Center for Global Nursing, is help partner folks that are nearby each other that have the same challenges and ideas. When somebody calls me from Malawi and says I need help with this, I was like, have you talked to my partner in Tanzania? Because maybe you guys, because maybe I actually don't know. And we have to know when we know, we have to know when we don't know. But I think this is another innovative way to kind of build capacity, inspiration, and help each other grow. So briefly about multidisciplinary collaboration. Obviously, I am super biased as an advanced practice provider. I love working with all people. I feel like I'm a nurse. I also have the role of a provider. I work really closely with my physician colleagues who I love and respect. And I think that in all of our training and in all of our role, we all have so much to offer. And without one another, we can't really optimize care for our patients. And so where are some of the opportunities? Like I thrive in multidisciplinary environments because a lot of what I do, it focuses on health system training, strengthening quality of care, and education and training, all of which need all of us to participate. As Teresa said, I'm working on the basic critical care course with WHO and PAHO and in Belize, and we were teaching everybody how to build bubble CPAP for infants with our WHO guidelines. And this is yay. But like these are our physicians and our nurses working together to make this happen. And we're actually, after this pilot that we did in March, we're doing a follow-up study, asking them and doing some qualitative work, asking what they thought, because this is a multidisciplinary taught course meant to be done together. And there's a lot of interesting data coming from their interviews about why they think it's really helpful that we're teaching everybody together. They're like, well, we work as a team, so why don't we train as a team? We should all have the same mental model. We should all have the same context. And I think that's a lot of like the stuff that we do here when we do like mock codes trainings together in our PICU. We get everybody in the same team, everybody in the same mental model. So there's a lot of opportunity for education and training together. I know in Lao, we did all of our simulation stuff together and some of our, basic ECG, stuff like that training. It was really helpful. Also, there's a group called EECC, Essential Emergency and Critical Care, that I got to get invited to work with them as they're working with the Ministry of Health in Tanzania to build up basic emergency and critical care services, and that includes nurses. So you can't do vital signs, you can't provide fluids or oxygen without nurses. And so originally it was a lot of physicians involved in that project, and now they're like, well, who's going to do that? And so that's kind of like, what's your role as you join and you like come into your roles as like, pediatric specialists in global health, like what do you guys get to do? And I urge you for these 4 things. Inclusion, I want you to know the role of nursing and make sure that they're included in the discussions. Partner with them on initiatives that have multidisciplinary impact or need stakeholders from all the different people. Try to understand and learn from them. They have a lot of training and education, and we don't want to assume that we understand their role or their knowledge or their struggles, and we want to work together. And then advocate. If you're in a position of power, because for some reason there's this, I'll call it the patriarchy of medicine, but somehow physicians always have a seat at the table, and you'll go somewhere and you'll be like, well, why isn't there a nurse here? You're talking about sepsis? Well, who's gonna take the vital signs and identify that the patient has a fever? Who's going to put in the IV? Who's going to give the antibiotics? Who's going to prepare the antibiotics? In 99% of countries that I've worked in, that's the nurse. And so they should be at that table. They should be with you. So your role is to, I have this fellow that I work with at Hopkins, and she's been sitting there. She's like, she calls me. She's like, I asked them, where's the nurse? In this discussion. And I was like, that's good, because I would do the same if there wasn't a physician at the table, or if there's not a physical therapist, and this is an early mobilization discussion, or we really need to recognize each other and each other's skills so that we make sure that the right people are there, so that the work that we're doing is meaningful and impactful. And we know that we work in healthcare systems and teams, and so having that team all together is really what I think just creates the most impact. And I know that that's all of our goal at the end of the day. And you should check out the Center for Global Nursing. We have a new website. It's really exciting. And if you know any nurses that you hear about that want to do this work or be involved, or if you ever want to partner with us in the future, please reach out. We love what we do and are excited for all of you, and here to answer any questions. Yeah.
any ways that like physician assistant, physician associates are involved in
Yeah.
the global argument?
They're actually, so there's a lot of data, that's in my other talk for advanced
Yeah.
practice, but yes, no, because, and at the, I should say at the Center for Global Nursing, we, physician assistants, soon to be physician associates are included in our community, and it's clear all over our website, because we really refer to it nursing advanced practice providers, which is as UCSF Health this defines as all advanced practice providers, include the physician assistants. And I think they have a very similar role. I think the challenge is really on the global structure of healthcare services, that there's not a direct counterpart with, like, so nursing, people feel really comfortable understanding who I am. But as a nurse practitioner, still, like, it's challenging. And because I'm not an independent provider here in critical care, I'm also not going to go somewhere and be an independent provider, because that's not my scope here. That's not going to be my scope there. So I work more in an advisory role and in a consulting role. And I think physician assistants, I think depending on if they're able to like work alongside of folks, a lot of the physician assistants I work with, I work in neurosurgery, they do a lot of amazing OR work. Could they go and train in the operating room with other surgical techs or surgical nurses or physician or medical officers? Sure. The closest thing to physician assistant is the medical officer when you look at a non-nurse trained provider, but it's very different. If you go to Liberia, I was just in Liberia a year ago, and they have a diploma, and our physician assistants have a master's. And so the level of respect, the level of funding, their pay, it's so different. And there's actually a lot of rifts kind of between the nursing and the medical officer world, more than there are between nurse practitioners and physician assistants, because their nurses are paid less than medical officers, but they have a same degree, like same level of practice. So, but they really, I mean, when I talked to the ones in Liberia that were at our basic critical care pilot program, I mean, they're in rural areas by themselves, providing family medical services. They're filling that gap. They're doing incredible work, and they were like, we struggle with being recognized by our government. We struggle with our pay. We struggle. We want to grow and we want to expand. But I know that there's organizations dedicated and working with medical officers and physician assistants around the world to kind of expand that and get it more recognized by the WHO, et cetera, as meaningful and necessary parts of our healthcare services, especially as we have a lack of physician trained providers. They're amazing. Medical officers, physician assistants, I mean, I'm a nurse practitioner. I think I'm amazing, you know. No, but I mean, I think, right, we all have a place, and we talked, I think what was really clear in this talk when I was putting it together was, you know, the shortage of healthcare workforce, like, so none of us are in competition. Like, we all really need to, like, how can we use all of our skills at the highest level, work together and provide the care that we need? I mean, that's like the answer. So it's like, not nurse, go follow my orders, but it's like, what can you do, and what are your skills, and where does the leadership see nursing growing, and how, you know, I've worked in institutions where I've come in and the director of nursing and director of medicine are like, we want our nurses to manage these things independently, and like, how can we get there? And then I've come to other places and they're like, the nurses are not allowed to do that, and you know, so I think it's really helpful when the WHO and ICN do all this work to the higher levels so that it reaches down lower, but also partnering and showing people. I think with the conference that we had in Kenya, I shared with them about advanced practice nursing in the US, and then we had them share their advanced practice nurse, who I adore, who works in the NICU. So I walked in and it was a 56-day physician strike, so she was the only one managing a huge NICU, and she was doing compressions and calm as cucumber and just magical person.
She's like, whoa.
Yeah. I mean, she was in her element of doing magical and wonderful things, and practicing at her full scope and trying really hard in the challenges that they had with this 56-day physician strike. But you know, I think there's a lot of I think we have a lot of opportunity to align, to strategize, and to build each other up.
Yeah. I learned that the California Nursing Union is like one of the biggest unions in the world. But are there unions like that are that strong in other countries?
It's a little different.
Yeah.
And no.
Yeah.
Yeah. The short answer is no.
Okay.
There are some, but they're bigger in high income countries. There's fees associated, there's organizational stuff.
Yeah.
If you're it's not prominent in low middle income countries
Gotcha.
in terms of the same benefit and force.
Yeah.
There's a question in the chat. So are there any current global health nursing opportunities in primary care for pediatrics? And if so, what's the best way to get involved?
Sorry to read. I'm a reader.
Okay.
Oh, yeah. So if for nurses that want to get involved, definitely check out our website. There's places there for our community. So anybody that wants to even just get our newsletter, but then there's people that want to become members. If you want to partner with us, there's a link. There's lots of different opportunities. We're working on a lot of strategies to really work with our colleagues actually, because Institute of Global Health Sciences is amazing and huge, and we're new to it. And there's a whole group of physicians that are doing, and researchers that are doing this incredible work that want to partner with nurses. So we need to know, we've spent a long time in the last year and a half getting to know who is our nurses and advanced practice providers that really want to be involved in the work that we're doing. And then once we know what people want to do, we can seek those opportunities, and we're building them slowly but surely. Oh, good. Oh, yes. You should reach out. We have students in our center. Is there another one?
Both asking how to get involved. Yeah.
Oh, yes, please, globalnursing.ucsf.edu. We also have Instagram and LinkedIn now, which I'm just really excited about because, when you build something from the ground, it takes some time to really get to be able to share what you're doing and connect to the community. And we're really excited to be growing and have the support of what's really exciting about the center is that we have the support of our dean at the School of Nursing, and then we have the support of our chief nursing executive at the health center side. And our big thing, is we don't want nurses to leave the field. We don't want nurses that love nursing to quit just because they want to be involved in things that they don't have those opportunities for. So we're launching a certificate program in global nursing next year, which we're really excited about, and lots of partnership opportunities. So more to come.
For those online, Tiffany dropped a survey link in the chat, and then I think we can send it out to you guys as well. It's just a very brief 3 questions to let us know how the session was and the lecture series in general. Any other questions?
Always reach out. We're always here. So great to meet everyone.
Did you see Zach Goodwin when you were in Eldoret?
No.
No.
Who's that?
He's